Hello, my name is Saad Usmani. I'm the Chief of Myeloma Service at the Memorial Sloan Kettering Cancer Center. I'm here at the ASH annual meeting, and I'm presenting on behalf of my co-authors the study titled DREAM9, Phase 1 study of belantamab mafodotin plus standard of care in patients with transplant ineligible newly diagnosed multiple myeloma. Let me share some background and some of the results. We know that VRD or bortezomib, lenalidomide, and dexamethasone is one of the standard of care first-line treatments for transplant ineligible patients, and then we utilize it either in a dose attenuated fashion or the usual fashion, depending on the setting. We also know that belantamab mafodotin is the first BCMA-directed antibody-drug conjugate that's been approved for advanced relapse refractory myeloma patients based on the DREAM2 study. And here, the aim of this study was to look at the safety and tolerability of combining belamaf with VRD in up to 8 different cohorts and up to 144 transplant ineligible newly diagnosed patients to figure out the optimal dose and schedule in this combination. And I presented on a total of 62 patients that have been enrolled, specifically focusing on the 36 patients in cohorts 1 through 5. What we found across these 5 different cohorts, the most follow-up was with cohort 1. The dosing utilized for belantamab mafodotin was 1.9 milligram per kilogram every cycle for this cohort. But then for cohorts 2 through 5, the dosing was 1.9 every other cycle or 1.4 milligram per kilogram, once every cycle or every other cycle, as well as the dose of 1 milligram per kilogram. So the most common AEs that were observed across each of these cohorts were thrombocytopenia, neutropenia, and corneal events. Any grade corneal events were observed across all cohorts. Grade 3 or higher, were different for different cohorts, anywhere from 33 to 83% of the patients, and had to do with, the higher dose and more frequent administration. But no patients had any permanent discontinuations. In the preliminary efficacy data, overall response rate was 100% in cohorts 1, 3, and 5, and 83% in cohorts 2 and 4. And the median follow-up is the longest for cohort 1 at almost 13 months, and it's only about 4 months for the rest of the 4 cohorts. So we just have to keep that in mind, as the data and follow-up matures, we will see the responses deepening as well. In cohort 1, 9 out of the 12 patients had a VGPR or better and had MRD testing done. And of these patients, 7 actually achieved MRD negative status at 10 to the minus 5 using NGS, after their first VGPR. The data on the other cohorts is not available at this time, but we're hoping that we can update these data at a future meeting, probably next year. And I'd be happy to share more updates at that time with all of you. Thank you so much for listening to me.